Welcome to today's episode of the Paula Briggs podcast. We're going to talk about premenstrual syndrome. Many women suffer from premenstrual symptoms to one degree or another, but because there are no licensed treatments, many women are not offered the treatments which could help make their quality of life better. So I hope you enjoy the podcast, and any questions should be directed to paulabriggspodcast@gmail.com. So I'd like to share with you some tips for managing women with premenstrual syndrome in primary care, leaving only the more severe end of the spectrum requiring referral to secondary care gynaecology. So what I'm hoping is that we will unlock the mystery really around premenstrual syndrome. I think many people are skeptical about this diagnosis, and I think the reason for that is that there are no licensed treatments. But it's very difficult for women who are affected. I think there's no doubt that some women find their own hormones very difficult to deal with. So we mentioned before in some of the previous podcasts about hormones and their receptors being like a key in a lock. And I think there are some similarities with some of the theories about what causes premenstrual syndrome, which is a British terminology, or PMDD, which is more of an American terminology. Recently, I was involved in a clinical trial looking for a drug which we had hoped would be the first licensed treatment for PMDD. And this drug was called sopranolone, which is a drug which would have blocked the receptor for allopregnanolone, which is a metabolite of progesterone. And that's the important hormone in women who suffer from PMS. So female fetuses have 2 million eggs. By puberty, there are about 250,000 eggs remaining. And by menopause, as you'll remember, the source is virtually depleted. And in the intervening reproductive years, women have 300 to 400 ovulations, depending on a number of things, including pregnancies and what type of contraception they might use. There are many disorders associated with the ovary's hormonal function, and some of these are associated with completely normal hormone levels, and PMS, PMDD is one of those. So the presentation today addresses two female organs, the ovaries, which produce cyclical hormones. And as I said before, we're interested in the hormones in the second half of the cycle. And I think you probably remember from one of the previous lectures when we talked about ovulation, that the corpus luteum produces progesterone. And also, we're going to think about one of its metabolites, allopregnanolone, which has exactly the same pattern of secretion, and that's the key hormone we think in relation to PMS. But I have to say, despite many, many years of research, there is still a huge amount of uncertainty as to why some women develop PMS and others don't. And there are no tests to determine whether a woman has this condition, because the problem is her own changing hormones. So the second gynecological organ is the female brain, which is very, very complicated. And I think maybe one of the reasons why people have shied away from managing women who have PMS is because it is a very, very complicated issue. That said, it can have a devastating effect on not just the women's lives, but those of their families, their partners, their work colleagues. And some women will even be driven to suicide attempts, and on some occasions they may be successful. So these are women who come to you with a problem, any one of the symptoms which you see there, and these need to be taken extremely seriously, because although there are no licensed treatments, there are ways of making the symptoms more tolerable. So in addition to the psychological symptoms, there are also many physical symptoms. due to the effects of hormones on peripheral organs. So one of the issues for some women suffering from PMS is fluid retention, which can cause breast tenderness, bloating, headaches, and make them feel really quite unwell. So as I've hinted, the impact on women and those round about them can be enormous. The most severe psychological form of this disorder is known in DSM-5 of the American Psychiatric Association as premenstrual dysphoric disorder, or PMDD. And many women will come having Googled information and already made that diagnosis themselves, but it's the same as severe end PMS. And one of the limitations of the DSM-5 diagnosis was that it had less focus on physical symptoms, which can be very problematic. And with the RCOG terminology, PMS, really it's not specific enough. So we haven't really had a good diagnostic description to date. What we do know is that women are symptomatic following ovulation. Their symptoms are relieved by menstruation. So that's when you want to make your diagnosis, when the patient feels normal. And that's certainly when you are better to engage with her, because that will be a more productive consultation. And the most important thing in women who have PMS is that there is significant impairment. Because going back to what I said before, she has the same hormones as anybody else, but for her, the impact makes her quality of life impaired, and those round about her. So we're dealing here with a spectrum. All women who are not using hormonal contraception and who are ovulating will have an element of, potentially an element of premenstrual irritability. So very few women have no symptoms whatsoever associated with their menstrual cycle. A smaller proportion will have premenstrual syndrome, and a very small proportion will have that more extreme end of the spectrum. Now, with the favoured term, I think, even for the patient population, being PMDD. But I think we have to accept that that is a psychiatric diagnosis. But the most important thing is that women who are affected are normal post-menstruation. So they no longer have those symptoms. Not that they're abnormal, that's probably not quite the right way to describe that. So this is the International Society of Premenstrual Disorder classification, and I think it's very useful. So we have core PMD, premenstrual disorder, which can have either primary psychological symptoms or primarily physical symptoms, or a mixed pattern, or severe end of the spectrum, PMDD. And then there is variant PMD. So these are women who may have just an exacerbation of depression premenstrually. They may have an exacerbation of physical illness like asthma, or their diabetes control may be affected. In women who, for example, have had an endometrial ablation, there'll be no menstruation, but there will still be a cyclical element to the patient's symptoms. Some women are, in some women, symptoms of PMS are triggered by the use of progestogens, which again from previous lectures you'll remember are synthetic hormones with progesterone-like activity. Mirena is a prime example. So you fit a Mirena in a woman who has heavy menstrual bleeding, needs contraception, but you don't realise that she has premenstrual syndrome, and then she feels like she has premenstrual syndrome all the time. In those women, the Mirena should be removed, and it should be removed quickly, because that can make them feel quite unwell. And then there's a small group of women who have anovulatory variant PMD. So they're not actually ovulating, and that's quite hard, I think, to understand. But it's just, I think this slide just is useful so that you can see that we're not just dealing with one thing. It's a little bit more complicated. So How is premenstrual syndrome diagnosed? This is something which can be done in primary care. It should be diagnosed following a prospective recording of symptoms. If a patient comes to you, and they will often come with a partner, to say, I've been tracking my cycle, I realise that I've got PMS, it's probably better if you make a clear prospective diagnosis using either the daily recording of the severity of the problem, or I favour the use of an app, which a colleague of mine, two colleagues of mine developed, because I think it's very much easier then for patients to email you the graphs. I think patients find the communication supportive, and the app will help with the diagnosis. So this is the daily recording of the severity of the problem. It covers a number of areas, including depression, anxiety, labile, mood, anger, irritability, changes in appetite, sleep pattern, losing control. And ideally, women would be asked to complete this on a daily basis. Sometimes women with PMS, particularly premenstrually, are unable to complete either the paper version or the app, Prementrix, which is available from the App Store. It's inexpensive, it's easy to use. Most people now are happy using technology like this. So this is the kind of symptom scoring chart that the patient will see. This is the graph that would be produced. So M is menstruation. You can see in this patient that she is scoring much higher before menstruation than she is post-menstruation. And you can also see here that the app gives a diagnosis of moderate to severe premenstrual syndrome. So it's helpful, but it's also useful to perhaps look at the app yourself so that you can become familiar with how it works. There are green top guidelines which have been produced by the RCOG to help with treatment options. And it's thought that diuretics can be useful in treating PMS, particularly in those women who have more severe physical symptoms. Spironolactone will prevent fluid retention. And if you remember back to the lecture on contraception, drospirenone, which is in some of the contraceptive pills, is very similar. It's derived from spironolactone, and that progestogen will prevent fluid retention. And so out of all of the combined pills, the pills which contain drospirenone, and there are more than one, and of course there are the branded generics as well, but they have an obvious particular place. And so many women who have PMS are unable to tolerate some of the other pills because of the progestogen component. So there are different ways of achieving treatment. We can either prevent ovulation, and if you prevent ovulation, there's no corpus luteum and there is therefore no progesterone, or we can choose to modulate neurotransmission. And there are two ways of doing that. There is the impact of SSRIs, or in the study that we were involved in, we looked at the impact of allopregnanolone on the GABA receptor using the drug sopranolone, which unfortunately, and there was an awful lot hinging on that trial, but unfortunately, the placebo effect overall was shown to be very high. So I want to start with the drugs which affect neurotransmission. Prozac is licensed in the States to treat PMDD, but any SSRI will be helpful. For women who have PMS, Prozac works in a very different way to how it works in depression, and it works very quickly. So it is reasonable for women to be treated only when they're symptomatic. And some women find taking a drug all the time and at a time when they would otherwise be well is not something that they want to do. So I think offering that option of cyclical Prozac can be very helpful. 20 milligrams has been shown to be effective in clinical trials. I'm just being very patient, waiting for the slide to change. And now I want to cover ovulation inhibition. So this can be done with combined oral contraceptives, so combined pills. You can inhibit ovulation with progestogens, but that's not ideal when we consider that the hormone that's the problem in women with PMS is a progestogen. So you could go from having cyclical symptoms to having continual symptoms. Mirena doesn't inhibit ovulation, and Mirena on its own is not a treatment for PMS. Mirena with sufficient estrogen to inhibit the cycle is what potentially may work. But as I said, some women are so sensitive to progestogens that they cannot tolerate the levonorgestrel released by Mirena. Many years ago when I started in gynecology, we used danazol, but the side effects were prohibitive. It can cause facial hair, excess hair elsewhere. And I think since kind of 1990, I've not seen danazol used, although it does work, allegedly. And so the non-contraceptive estrogens are basically estrogen like you would get in HRT, so either patches or gels, and you need a high enough dose to override the natural cycle. So you're talking about 100 milligram patch or 4 pumps of estrogel, or we now have Lenzetto, which is a spray, and you would be looking at least 2 sprays of Lenzetto, maybe more. GnRH analogues will inhibit the cycle from above. So they do that very successfully. And when you understand the theory of PMS, you will understand why this works. Now, you can't stop somebody's cycle without potentially increasing the risk of osteoporosis. And so for most women, we use add-back estrogen. If they have a uterus, that's a problem because we need to use a progestogen to protect against endometrial hyperplasia. So you can see that that could be a problem, but in some women who are severely affected with PMS, they may be intolerant to estrogen as well. So again, this is the whole point about making a clear diagnosis based on a prospective recording of the symptoms, because if a hysterectomy and bilateral oophorectomy is going to be contemplated, then that should be done based on a very robust diagnosis. There are other psychiatric conditions like rapid cycling bipolar disorder, which can be confused with PMS. And the worst thing that we could do would be to remove a healthy uterus and ovaries and for the woman still to remain symptomatic. So my clinical practice with GnRH analogues is to use 12 weekly injections to avoid any flare. On the second injection, in the last 6 weeks, I add back estrogen only to ensure that the patient can tolerate that. And then I would be prepared to refer on, if the patient felt well with add back estrogen alone, for that patient to be considered for surgical intervention. So with combined pills, I've already said that some of the combined pills are not well tolerated. So if you think back to the contraception lecture, we have first, second, and third generation progestogens. That would be norethisterone first generation, levonorgestrel second generation. Third generation is gestadine and desogestrel. Now, women with PMS may be unable to tolerate any of those groups, but they may be able to tolerate drospirenone, which some people refer to as a fourth generation. Others think of that as sitting in a class of its own, with it being similar to spironolactone. So Eloine is a pill which is identical to Yaz. I know we shouldn't talk about branded names, but it's easier here to get this right. We had Daylette before, which was identical, but the only version of this pill which has 20 micrograms of ethinyl estradiol and 3 milligrams of drospirenone is Eloine. So there are 24 active pills and 4 placebo pills. For women who have PMS, it would be reasonable to miss the placebo pills to prevent any hormone withdrawal symptoms. So if you get somebody stable, the last thing you want to do is destabilize them by disrupting stability. I think, thinking back to what we've talked about already, and thinking back to that kind of basic chicken wire structure of sex steroid hormones, you can understand why some women find it difficult to tolerate estrogen. It's not that dissimilar in appearance to progestogens. It will have some impact on the progesterone receptor, although, back to our lock and key theory, it doesn't fit into the lock with an exact fit. So for those women who can tolerate an IUS, that provides excellent endometrial protection. They will absorb more in the first 6 weeks. So if you can support them through the first 6 weeks, then the amount of levonorgestrel in the systemic circulation will drop. And then, as I said before, to suppress ovulation, you need at least 100 milligram patch or sufficient gel or spray. And that's going back to the whole hypothalamal pituitary axis. So, Green Top Guideline number 48 is very good. It's certainly worth looking at. Many of you who are listening to this podcast may have been skeptical about PMS in the past, and it's just useful to know that that resource is there, and that the vast majority of what we've talked about already can be done in primary care. So before a woman is referred, it would be advisable to ensure that she has tried cognitive behavioural therapy. Following a risk assessment, if eligible, she has been trialled on a combined pill such as Eloine, and ideally Eloine. There are other things which have been mooted as being potentially successful in women with PMS, vitamin B6, calcium. There are Agnes cactus. I mean, we can't really recommend those as doctors, but patients can go to a health food store and ask for help. SSRIs. And so these are all the things which I would expect a good GP to have considered. Many GPs will also fit Mirena, and now that you understand that it's not just Mirena, but with the addition of a high dose add-back estrogen, then many of your patients can be successfully managed in primary care. And actually, I think sometimes it's better you build a different relationship with patients than you would do in a secondary care setting. However, for those that don't respond, and if you are going to refer on, it should really be to a gynaecologist who has an interest in PMS. And these are few and far between. It's linked in many ways to managing the menopause because of the kind of hormone therapy. So British Menopause Society has a guide of menopause experts that would give you some idea throughout the UK of where you might find clinicians who have expertise or interest in PMS. And actually most PMS experts are known to each other, so I'm sure would help if you were in an area where you were unsure whether there was a menopause expert, a PMS expert there or not. So we've already said that GnRH analogues can be very effective. I wouldn't expect you to necessarily initiate these in primary care, and I think it is important that the prospective rating, if at all possible, is done before a GnRH analogue is administered. However, on rare occasions, if a woman is suicidal, then of course you have to take the decision as to whether you start a GnRH analogue early rather than waiting for referral to secondary care. Tibolone can be used as add-back. Tibolone is basically a progestogen with estrogenic, progestogenic and androgenic activity, so again it may not be tolerated. Women who are having no add-back should have a DEXA scan to ensure that there's been no detrimental effect on their bone mineral density. So, it can be difficult with add-back, although it's not thought to impede the effect of GnRH analogues. That's all down to the individual patient and how she responds. So this is the concluding slide, and I hope is a useful go-to summary. In fact, it may be worth having this as a standalone laminated card. Just to remind you that the diagnosis should be based prospectively on 2 months information collected on the daily severity of the problem. If you are going to refer on to gynecology, make sure it's to a gynecologist who's interested. If you are going to treat, which I hope you will do, then base this on a risk assessment. You want to make sure if you're going to use the combined pill that your patient does not have migraine with aura. doesn't have a family history of venous thromboembolism in a first-degree relative under the age of 45, because that will potentially increase your patient's risk of having a DVT or a pulmonary embolus. Make sure that their body mass index is not over 40 and that their blood pressure is controlled. And it's also worth ensuring that they're not on any other enzyme-inducing drugs, particularly if they're going to use the pill that you prescribe for contraception. If you're going to use SSRIs, there is the option to use these in the luteal phase only, and there are choices, although my go-to SSRI is Prozac. Mirena will provide endometrial protection only. It is not sufficient to manage PMS, and women who use Mirena are using it as part of a package with add-back high-dose estrogen. I don't use danazol, but it's there as an option, and it's included in the RCOG Green Top guideline. GnRH analogues are an option. Depending on your level of expertise and confidence, you may choose to use these in primary care or to refer on. And then, the end stage treatment would be surgical, and there is absolutely no point in removing a woman's ovaries and leaving behind her uterus, because you're then stuck with the problem of endometrial protection. So if a woman is going to have surgery, she should have both her uterus and ovaries removed. And clearly it's important to ascertain whether or not her family is complete if you are looking at surgical treatment options. And any woman who is going to have such radical surgery should have had a GnRH with estrogen add-back test drive. So just to finish off, we had very, very high hopes for sopranolone. Trials are ongoing using sopranolone to treat migraine with aura and Tourette's. So it may be in the future that we will be able to use the drug out of license to treat PMDD. We had patients in the trial in Liverpool who responded incredibly well, who were crying when the trial was over because they could no longer access the drug. So personally, I don't believe that to be a wholly placebo effect. And I think it is frustrating when we've been looking for so long for a cure. So thank you for listening. We will be with you with the next podcast, which is on polycystic ovarian syndrome, very soon.